I hope you enjoyed the recordings, and this is we're very fortunate to have all three scientists with us. So often they're on stage, they're invited to give speeches, and you're in the audience, but here's an opportunity to ask questions up close and personal. And so some of you have jotted down questions during the presentation itself, and I'm going to share some of those and query them, but please know that you're online now, and I'm going to relay some of those questions as we go, so don't be shy. So just to get us kicked off, can I ask each person to, again, remind the audience who you are, where you are, and what your area of specialty, starting with Colleen.
Hi, I'm Colleen Laprell. I'm a professor at the University of Texas at Dallas, and I'm also the head of the Communication Sciences and Disorders program, which is housed at the Callier Center down in Dallas. My work has focused on noise-induced hearing loss. In particular, its prevention. We're very interested in the methods of injury and the development of strategies to try and prevent hearing loss. That can include dietary supplements, drugs, and also the use of earplugs and propagation of safer listening behaviors.
Great. Thank you. Lynn?
Hi, I'm Dr. Lynn Henselman, and I'm a senior healthcare consultant with the Department of Defense's Hearing Center of Excellence. I was formerly its deputy director until I retired from the Department of Veterans Affairs. I am a military retiree. I spent 20 years in the Army as an Army audiologist, and my focus there was noise-induced hearing loss and tinnitus and hearing conservation programs for the military.
Great. And Rich Tyler.
Hi, I'm a professor in the Department of Otolaryngology, Head and Neck Surgery, and the Department of Communication Sciences and Disorders at the University of Iowa. I'm trained as an audiologist and then did a PhD in psychoacoustics. So I've see tinnitus patients every week, but also do a lot of research, and I've done a lot of research in the area of cochlear implants and also in the areas of tinnitus and hyperacusis, and glad to be here.
Thank you. Thank you to all our speakers. I think what I'm going to do is jump in and start the questions and answer session. So please, again, listeners, type different questions you might have in the chat area, and I'll relay them on. Well, we may not be able to get through all of them, but we do have an hour dedicated to this. So also let your friends and colleagues know to join us if they're not online, because they'll have an opportunity to answer their own questions. So starting with you, Rich, there was a question about tinnitus matching, and that their audiologists provide this service, or they use this during their audiological appointment. And could you describe that a little bit, and what the purpose of it and what your impressions of that technique is?
So if I understand correctly, matching would mean trying to produce an acoustical signal that has similar characteristics to what the patient actually hears. So for example, people can hear a high-pitched ringing or a roaring noise, and everybody's description is somewhat different. And sometimes this is helpful in actually measuring and quantifying the tinnitus. So for example, you can adjust a pulse peer tone to try and determine the most prominent pitch of the tinnitus by equating that to the pitch of a pure tone. You can also determine the equivalent loudness of the tinnitus by adjusting the intensity of a tone so it is equally as loud as the tinnitus. And then the other measurement that is commonly used is the masking of the tinnitus. So tinnitus cannot always be masked, but in some situations, for example, you can use a broadband noise to increase the level gradually until the tinnitus can no longer be heard. and that is referred to as the minimum masking level. So these measurements can be very helpful and somewhat required in experimental trials of tinnitus to try and determine the magnitude of the tinnitus or its characteristics, and to see if that can be changed in a careful way by some treatment. It's also often helpful just in terms of counseling to show the patient that indeed they actually have something real. There's not making this up. This can actually be measured, and that is reassuring for lots of patients. And then there are some devices that are used clinically that require measurements of the tinnitus, for example, to adjust the spectrum of a broadband noise, or to find a notch in a broadband noise or music that might be helpful. So those are the different ways, generally speaking, that tinnitus can be quantified by measuring it and how it might be used.
So a follow-up comment then, Rich, was from an audiologist who's listening right now, and saying then you would describe them as being accurate and appropriate for tinnitus evaluation.
Well, we do not always do it for every single patient clinically. So clinically, it can be helpful, as I mentioned, but it's not always done clinically, at least for us. I'm also going to say that the test-retest reliability can be quite complicated in some patients. Sometimes the actual test stimulus itself can actually change the tinnitus that the person is listening to, which complicates its measurement as well. And so, for example, in an experimental design, experimental treatment of tinnitus, you would want to know in the minimum masking level. And again, we would always use the stimuli that we're using, we would always use in a pulsed mode, so we don't have to worry about adaptation effects. But you would always want to know what the test-retest reliability is for that individual before you were able to document that the tinnitus changed in some way in that individual. So indeed, it is complicated to measure. It's highly variable in some patients, and it may or may not be used clinically or even in research designs, depending upon what the motivation is and what the interest is in the actual experimental design or clinical application.
Okay, thank you for clarifying that. Carrying over on the assessment theme of tinnitus and thinking about audiological services and interventions, Lynn, I want to share a question with you that a listener asked about the role of head injury and thinking about potential causes and population that you deal with. Is there evidence that head injury or trauma can result in tinnitus and or vertigo?
It is often associated. Traumatic brain injury also has an association of tinnitus with it. I mentioned that in part in my presentation. We're still learning a lot about traumatic brain injury and about the effects of different types of injuries that affect the brain, whether it be a blast or a penetrating injury. But there is an association between tinnitus and traumatic brain injury in many cases, and also with post-traumatic stress disorder.
And what about processing disorder? So not just ringing, but being able to make use of your hearing in noisy situations or even quiet situations.
Well, I'm glad you bring that up, because we actually have another working group at the Hearing Center of Excellence that's looking at specific problems with processing in our military, our active duty, and our veteran population. We've heard, a lot from the clinicians that they're seeing, through the course of these wars, they're seeing a lot of patients come back that maybe had traumatic brain injury, or maybe didn't, not a real severe injury, but we're having difficulties in certain listening situations, especially when there's background noise. So, we know that central auditory processing disorders are still controversial in terms of how to assess them, how to diagnose them, how to treat them. We're looking with our working group. It's a DoD-VA working group. We are looking at, what are we seeing that's unique within our military population, and what are some evidence, and we still need a lot of evidence. We don't have it all. What are the best tests to evaluate? We're trying to survey the testing, and we're surveying what's out there for treatment. But what we've learned is how much we don't know yet, and that there isn't a lot of evidence base. But we do know that cognition is affected with traumatic brain injury, and that may impact the auditory processing. And the brain is so complex that is the area where you're seeing some functional problems with that veteran or that service member a result of some sort of other cognitive problem, or is it directly related to the auditory processing part of the brain? So there's a lot to be learned, but we do know that there's, we're seeing some difficulties in patients with traumatic brain injury in terms of their ability to, not only with hearing loss, but also with processing the information that they receive.
Great. So just one clarification, if it helps the listeners. We use the word processing to describe how people make use of sounds in their environment. And sometimes it can be very difficult to hear or understand or follow instructions, even when your hearing test suggests that your ears are working fine. And then there's the case where you may have some hearing loss and you're wearing hearing aids, so sounds are loud enough, but they're still not clear, and it's still difficult to follow and make use of that information. So when we speak about those types of symptoms, we often refer them to processing, a central auditory, how the brain is making use of that sound and extracting signals from noise. So thank you for that question, and it allows us to share a little bit more information about how we hear. So Colleen, one of the questions that people are asking is you showed that slide about the relationship between tinnitus and diet, which, considering that if there is no cure, it's exciting to think, well, maybe there is something we do have a little bit of control over, and that's monitoring our diet. So what is healthy eating? What does a healthy diet look like? And what types of foods were determined to be healthy in the research studies that you shared?
Yeah, that's a great question. The way that we have looked at diet uses something called the Healthy Eating Index. And the Healthy Eating Index looks at all of the different aspects of what goes into a healthy diet. And so if you have high fruits and vegetables, there's a range of points. And if you're meeting the USRDA, then you would get 10 points for your fruits, 10 points for your vegetables. There is a healthy meat intake for things like sodium, and for fats, it's staying under a particular limit. So if you have a diet has no more than a particular cap on sodium. And so for our study, all of those pieces went into it, looking at relationships between noise and hearing and diet. The subparts of the healthy eating scale that were the most strongly correlated with the overall results were fruits and vegetables. And so we know that fruits and vegetables are very high in antioxidants, and antioxidants are one of the things that a lot of the pharmaceutical companies that are trying to develop protective agents are focusing on. So we think that fruits and vegetables are important. If you look across the whole wealth of literature for noise and hearing loss in particular, but also the emerging work that's being done with tinnitus and diet, you will very often see fruits and vegetables cited. There's also work looking at fish, high fish intake has been healthy in some studies. In other studies, they've looked at carbohydrates, low carbohydrates being associated with healthy hearing. One of the real challenges for this whole line of work is that very often diets that are healthy in one way are also healthy in other ways. And so if you have a diet that's heavily plant-based, heavily vegetable-based, a lot of fruits, it also will often be a lower sodium, lower carb kind of diet. And so it becomes very hard to tease out, is it the low sodium, is it the high fruits and vegetables, or is it the combination of those two that's important? And so we end up with some studies where they only look at one part of it. One of my favorite examples is a study from Japan where they looked at beta carotene levels. And they found that people who had very high beta carotene levels in the blood tended to have the best hearing. The problem is they didn't measure any of the other possible vitamins that could have been present or any other minerals. And so diets that are high in beta carotene are often also very high in vitamin C and vitamin E. And so we don't really know if it was truly the beta carotene having that effect or if it's other elements of the diet that are also increased as part of eating a diet that's rich in beta carotene. So that's a very long-winded way of saying that diets that follow good nutritional guidelines as a whole in terms of lots of fruits and vegetables, limited sodium, less carbs, tend to be associated with these results of less hearing loss and less tinnitus, but we don't know for sure which part of the diet is the most important or if it's that overall combination.
Well, I think that speaks to the point that even though we can't necessarily isolate one thing in relation to how it changes your tinnitus, it sounds like the healthy eating index or the recommendations that are being made are good for multiple ways of multiple aspects of health, whether it be cardiovascular, diabetes, and all these things.
Yeah.
So it's just another justification to know that eating healthy not only is good for the list of things that we already know, but adding tinnitus to that list is really, really compelling. Colleen, and a follow-up question is, in addition to diet and helping to potentially prevent or minimize tinnitus, you spoke about earplugs as well. And there are many, many different types of earplugs, which was great for our listeners to know. One of the comments that was made is that it can be frustrating when you have tinnitus, when you put earplugs in, that it can actually enhance the symptoms. So can you describe why that is and what kind of help you can recommend for our listener?
Yeah, that's a great question. And one of the things I would speculate is that if you put in an earplug, which has very good isolation of all of the external sound, then you're going to be blocking all of those external sounds that might be competing with and potentially masking your tinnitus. So your tinnitus is less obvious if there's other sounds going on around you. If you block all of those other sounds, it may be the only thing you're perceiving as hearing. One possibility is there are electronic, both earplugs and earmuffs, and
I think we may have lost Colleen.
Oh no.
Let's see. Okay, well, how about we turn this over to you, Rich?
We can still hear Colleen, so go ahead, Colleen. Keep going.
You can still hear me? Okay, good.
Thank you.
Yeah, so there's electronic earplugs as well as electronic earmuffs. And what those do is they allow all of the normal sound to enter into the ear canal. And so any of the environmental masking that you would typically benefit from when you're not wearing an earplug, you'll be getting that sound coming in through the electronic earplug. But then when sounds become too loud, that earplug or earmuff will work just like a traditional earplug or earmuff that blocks sounds that are too loud. And so those might be a good solution to at least consider trying.
Okay. Another question that came in, I'll turn over to Rich. Sorry, we may have some interruptions here in our connections, but I think we're handling it well. And if you hang on, we'll recover some video coverage or audio if we tend to lose it. So Rich, speaking about tinnitus, there's some interest in understanding maybe, is there a relationship between tinnitus and vertigo, and why might that be? Do you want to offer any suggestions about educating our listeners about the relationship, and if there are treatments that have those symptoms in mind, what you would recommend them to do in those cases when they have dual problems?
I'm not sure I have any good insights on that. I'll just say, of course, that the vestibular system is right beside the cochlea, and so it's not uncommon to have common problem areas. And that's probably about all I can add. Sorry.
So just the inherent proximity of the vestibular, those canals in relation to the cochlea, and maybe what modulates how they function on a neurochemical level may have some shared sources. Anyone else want to offer any insight, Lynn or Colleen?
I'd just like to say, for our service members and veterans that have traumatic brain injury, often, and again, these are patients with traumatic brain injury, that often there's vestibular issues and tinnitus issues. So again, the brain is so complex, and I can't offer much than that, but it's often associated as well. So.
Yeah, I don't have much to add. The effects of noise on the vestibular system are much less well understood.
Okay.
So Lynn, there's been a few requests for information about these services that you spoke about, and are they only limited to active members or service members or retired people who are veterans? Where can people who may not be affiliated with the military learn more about the information that you spoke about? And are there services for people who are non-military?
Well, the principles behind progressive tinnitus management, which is what the Department of Defense and the Department of Veterans Affairs uses for their beneficiaries, are also in many the same principles that Dr. Tyler was talking about in his program. So a lot of it is helping an individual to manage the reactions to the tinnitus, and to have a lot of it is through education, or sometimes cognitive behavioral therapy. Mindfulness is a way. So there are different disciplines that have been working in this area. So if someone is not associated with the military, there are many other programs that do exist with the same principles. Maybe a little bit different depending on the population, but it's this progressive approach for helping individuals who, depending on their level of bothersomeness with their tinnitus. So, Dr. Tyler, would you agree in the civilian sector?
Yeah, lots of different opportunities, both with specific counseling strategies for tinnitus, like tinnitus activities treatment, but there's also, as I say to the patients, that we all have challenges in life, all of us, and there are lots of things we can do, including meditation, garden therapy, art therapy, mindfulness, guided imagery to help us deal with things and relax and enjoy life in a different way. And especially if we're bothered by something like tinnitus, then having some opportunities during the day to relax and think about something else and enjoy life is good. And again, that's good for all of us.
Yeah. And just a comment, if someone on this call is a veteran or a service member, the way to get access to these services is to see an audiologist first for an evaluation. And there's various military hospitals, and in the VA, you no longer have to work through your primary care physician. We have direct access to audiologists. So if you were associated with a CBOC or a hospital, find out about getting an appointment with an audiologist, and they can start you on the journey to get progressive tinnitus management.
So one of the questions that came up was the idea of what is cognitive behavior therapy? Is it the same as mindfulness? Who is the professional that provides that service? And my understanding is that some audiologists are trained in that area, in those areas, and that there are multiple approaches to engaging in mindful approaches to tinnitus. But Rich, do you want to offer any other some directions of where people can find help? Is it always the audiologist, or are there websites that you can recommend? Certainly, maybe you can tell us a little about the American Tinnitus Association. Can you offer some resources to our listeners?
Well, certainly the American Tinnitus Association is an obvious one, but I'll say that in general, some audiologists feel comfortable providing detailed counseling and some do not. Sometimes we refer our patients to a psychologist or a psychiatrist. Sometimes we also get referrals from a psychiatrist or a psychologist back to us for the tinnitus patients. Cognitive behavior therapy has nothing to do with mindfulness, in my opinion. Cognitive behavior therapy is based on the principles that how you think about something and interpret something has an impact on your emotional reactions to it. And so changes on how you interpret things and think about what you're faced with is going to have an impact on your emotions. There are lots of strategies that includes, as I said, guided imagery and mindfulness and meditation that are good for all of us. Some people feel comfortable doing it. Some people don't. Some clinicians don't. And I'm going to say again that we're all different, and different approaches work good for different people. We all have challenges in life, and we can all help ourselves and help our clinicians or help our clients by focusing at a personal level with them and connecting to them, understanding their individual differences, their individual needs, and helping them as individual patients.
Okay, thank you for clarifying that. And then a follow-up question I'm seeing is then, would those recommendations differ, those approaches differ, whether you are a cochlear implant user, a hearing aid user, or even normal hearing user? Does it matter what your hearing status is and what you're using to have these as appropriate tools to help cope with tinnitus?
Well, I'm going to say for the counseling side of it, for the most part, the answer is it doesn't matter whether you're using hearing aids or cochlear implants or have a minimal hearing loss. It's the important thing is connecting with a clinician that can connect with you and understand your individual needs. And as long as you can hear and communicate, that's the first step.
Okay. So I'm going to share a few questions, just open it up to anyone who wants to answer some of these questions. Sometimes there's some confusion between what we call hyperacusis and loudness recruitment. So we have someone saying that they have been diagnosed with that. And what is the difference? Is there a difference? What does that mean? Anybody?
So I can take this on. So loudness recruitment is when you increase the level of a sound in somebody with a cochlear hearing loss, typically, that they have a hearing loss, so they don't hear sounds until 20 or 30 dBHL. And but there is a rapid growth of loudness as you increase the level of a sound, and so that they hear an intense sound that would be intense for a normal listener at 100 dBHL. That person with loudness recruitment would also hear that intense 100 dBHL sound as being very loud. And so that's their loudness growth is more rapid compared to somebody with normal hearing, but they hear their loudness discomfort levels are at the same level, about 100 dBHL, as a person with normal hearing. Somebody with hyperacusis, they experience loud sounds at a much lower level. So it might be 60 or 70 dBHL. And for them, the sounds might be way, way too loud. And that's what I refer to as loudness hyperacusis.
So both share principles of having a discomfort to an abnormally exaggerated discomfort to loud sounds, but the way in which they experience it might have two different types of mechanisms involved or things. So let's carry on that with another question that emerged, continuing on understanding tinnitus in relation to other types of disorders. Can someone describe auditory hallucinations and versus tinnitus? Those two things are sometimes used interchangeably. Are they the same? Are they different? I'll throw that out to anyone on the panel.
Well, I can say that I don't like to come up with several different clever names. So auditory, I typically refer to auditory hallucinations or hearing any sound that doesn't have an acoustic correlate. I refer to as tinnitus. And auditory hallucinations usually mean that the person is hearing a voice or music or something like that. And this, because of the complexity of what people hear, the likely mechanism of this is some hyperactivity in the auditory cortex. And Welder Penfield from Montreal years and years ago stimulated the auditory cortex of people he was working on, and people heard voices and music from direct electrical stimulation to the temporal lobe. So usually, of course, tinnitus is related to noise exposure or peripheral hearing loss of some sort. So in that sense, they likely have a different cause. And I would also just add as a final note that that the auditory hallucinations have to be distinguished between somebody who has a mental illness and other serious mental illness symptoms, and they can hear voices. And I usually make a distinction and do not call that tinnitus. That's a mental illness and have to be kept separate from auditory hallucinations from somebody who has a hyperactive temporal lobe and is hearing music or words.
So in that case, the example would be someone who thinks they're hearing voices that are telling them to act out in a certain way. That would be very different than an auditory hallucination that is the perception of sound that isn't there, that we would normally describe as tinnitus. Okay. The other term that people are asking for clarification on is, well, there's actually two more. One is musical ear syndrome. Is that a type of tinnitus? Anybody on the panel want to take a shot at that? Have you heard of that term before? I have to admit that I was not familiar with that term.
Well, I'll just say everybody keeps coming up with new clever terms to try and be unique and special. And I think I've heard of the term before, and maybe it relates to people that have tinnitus as a result of music. And sometimes the tinnitus is not always constant. Sometimes it can fluctuate. And again, as I said, sometimes for people that have a central nervous system disability, they can actually hear musical sounds as their tinnitus, not a constant tone or a noise.
Okay. One term that I think we all are familiar with is misophonia. So we're getting a question about misophonia. Can someone take a shot at that? No, more of the same then?
Well, I'll say it once again.
Yeah.
There's about 100 different names for hyperacusis now. Jastroboff made up the term misophonia, but sometimes when I'm in my conferences, we have competitions to see who can make up the name for these sorts of things. So there's about 5 or 10 common names for hyperacusis. And I think it's a mistake that we have to use simple terminology that the healthcare can use, the newspaper can use, the public can understand, hyperacusis we've been using for years. I refer to it as somebody has a problem with loudness. Some sounds are too loud. Some people are annoyed by sounds that are not intense. I call that annoyance hyperacusis. Some people are afraid to go places like restaurants or football games. I call that fear hyperacusis. And some people actually experience pain for moderately intense sounds, and I call that pain hyperacusis. So I think it's important to make the distinction between the actual the perception that people have. You have hyperacusis means an excessive response to sound, and then the way I think about it is that you have 4 possible reactions to those excessive sounds in a similar way in what I refer to as my psychological model of tinnitus. You have your tinnitus and you have your reactions to the tinnitus. And I try and think about hyperacusis in the same way.
Okay, so I think listeners, when we think about your individual experiences, it may be that your care providers uses different terms. It may be that when you Google the problem, multiple terms come up. But I think what you're hearing today is that in some ways they're all under the same umbrella, but they may be described differently based on the reaction it gives you. But certainly going to websites like the National Institutes of Health, the American Tinnitus Association, the Department of Defense, is where you can find some consistent literature and consistent information. Certainly going to the Hearing Loss Association of America. Our website provides information that you'll find helpful that is described in non-medical terms. And I think that those are all resources that are available to you as soon as we sign off today, that you can Google and learn more. So thinking more about, again, preventing tinnitus in the first place and why we can minimize our risks as it relates to noise exposure. Colleen, one of the questions has to do with genetic predispositions, or is just some people more predisposed to experiencing noise damage than others? Can you tell us a little bit about that?
Yeah, that's something that we're really interested in, is what predisposes one person to develop hearing loss more so than another person, because we clearly know that some people are much more vulnerable than others. Genetics is part of it. There are a handful of genes, at least a half a dozen genes, that are associated with increased vulnerability to noise injury. Some of those have to do with oxidative stress, as we've already talked about with fruits and vegetables being beneficial. Some of them have to do with what we would call potassium recycling. There's heat shock proteins. There's a host of different chemical cascades, that genes that contribute to those chemical cascades influence vulnerability. There are also some genes that have been associated with prevalence of tinnitus, in particular in people who have sound exposure. There's some work that was done with musicians recently, looking at the prevalence of tinnitus as a function of the gene expression in those musicians. So certainly genes are part of it. Diet, we think, is part of it. Things like cardiovascular disease. We know that restriction of the blood flow to the ear is a cause of trauma to the ear, a cause of hearing loss, and certainly there's a high correspondence between presence of hearing loss and presence of tinnitus. They don't go 100% together, but there is a significant overlap in those two deficits. One of the things that we've gotten interested in is ear canal acoustics. We know that sound is amplified much more in some ear canals than others, and so two people can be in the same noise environment, but one of them will have much more sound at the eardrum than the other. Some of the work by Greg Flamme and John Rosowski's labs are showing that sound is more efficiently transmitted from the middle ear into the inner ear in some ears than others. So how well the middle ear bones are moving sound from the tympanic membrane to the cochlea. So there are at least a half a dozen different individual factors that influence vulnerability both to noise injury and also potentially to tinnitus.
So thinking about that, is it safe to say, as I'm reading somebody asking, is it safe to assume that we're all vulnerable, and that if we're going into noisy environments, that we should take protection with us, whether they be the earplugs or avoid the sound altogether is another technique. Is it safe to say that nobody is exempt? Maybe some people may be more predisposed, but the opposite.
Yeah.
Is that no one is exempt from damage.
Right. No, I would say absolutely nobody is exempt. The point where damage begins might be a little bit different for each person. And so, in the talk that I gave, I talked a little bit about epidemiology and statistics and what % of people develop hearing loss with different exposures. But nobody is exempt. Nobody's ears are so tough that noise can't hurt them no matter how loud it is or how long the noise exposure lasts for. I do recommend hearing protection and routinely carry several sets with me so that for me or for my kids that I have enough pairs. In particular, things like musicians' earplugs, which provide a reduction in sound levels, but don't block all of the sound, so you're still able to hear music if that's what you're listening to. I try and do a lot of education of whoever I'm with. I took my daughter to her first concert with a friend who goes to a lot of concerts and offered both of them earplugs at the beginning, and my daughter took hers and her friend said, "Oh no, I go to concerts all the time and never wear earplugs." And I was like, well, why don't you just try them and see what you think? And so they took them, and about 5 minutes into the concert they said, okay, I'll give them a try, and then they wore them for the whole concert. So sometimes it's just a question of taking a chance on trying it and finding out it works. A lot of these products are not terribly expensive. You can order musicians' earplugs on Amazon, for anywhere from $10 to $50, depending what brand you go with. And the less expensive ones are not low-end ones. We've actually seen some of the most consistent results in terms of good fit and good sound quality with some of the $10 to $15 pairs of musicians' earplugs.
You raise a funny story that reminds me of being at a park event where there was live music on a stage, and there was a woman there with her child that was right next to the speakers. And it's hard not to be an advocate in Miss Bossy Pants when you're out, when you know about this and thinking, oh, you might want to step away from the speakers and you don't want to be appearing to police somebody. But she actually told me that they were training their daughter's ears to tolerate noise because her husband was one of the musicians, and they practiced in the garage all the time, and they felt that it was important to toughen her ears. And so I know that's not true. Maybe you can speak a little bit about the myth about toughening your ears.
So that's a really interesting area of work, Kelly. There actually is a phenomena called toughening,
Right.
and what and so what that phenomena is it's been shown very well in a number of different rodent models, and what they've found is if you expose the animals to a loud sound that causes a temporary change in their hearing, and you do this every day, that when you expose them to a louder, more traumatic sound at the end of the toughening period, they have less permanent threshold shift in response to that loud sound. But what I would really caution with that line of work is there's a number of studies that have come out just in the last 10 years, which are looking at changes in nerve pathology as a function of noise exposures that cause temporary threshold shift. And we have absolutely no idea if exposures that result in these hair cell toughening phenomena. Number one, we don't know if that occurs in humans, but number two, we don't know if the nerve fibers are being damaged at the same time as the hair cells are being toughened. And so I think it would be really risky to try and use toughening in humans as a way of protecting the ear at this point. We just don't have evidence that that's going to be safe or effective.
Right, right. And in contrast, we do know that excessive loud noise exposure will create damage to other structures. So,
right.
Okay. And so the other way we can prevent is, as you mentioned, understanding the sound levels around you. So using apps. So you mentioned the NIOSH sound level meter app that's on your phone. And so I just shared that link with people in the Q&A section, and it's for the Apple. But maybe can you tell us a little bit more about how people can use that information if they download that app? How would you recommend before you went into a concert or a restaurant? What do you recommend for our listeners?
Yeah, so there are hundreds. There's over 100 apps that are available out there. We've worked with several of them. Some of them have been very inaccurate, either in the direction of reporting sound levels as being higher than they really are, or reporting sound levels in the direction of being lower than they really are, which is, the big concern that somebody thinks they're safe staying somewhere when the levels are lower. The NIOSH app is one of the ones that has been very accurate, and we tested it across about 6 different generations of iPhones, and it was very accurate with all of the different generations. But the additional thing that we found with all of those different generations of phones is they all had different levels of abuse, and so the microphones were pretty resistant to damage, and the app did a really good job across all of those phones. So I particularly like that one. There is a calibration procedure if you want to verify the accuracy of the app. We have not actually used the calibration feature when we've looked at how accurate the app is, simply because many people who download the app are not going to take that extra step, and so we wanted to know how accurate the information was for somebody who just downloads the app and hits go. The great thing about the NIOSH app is it will give you information about how long you can safely stay in an environment, meaning how long you can be in that environment before you hit 100% of your noise dose. So it gives you some good projection information. The caveat that I raised before and that I'll repeat again here is, regardless of what the app says, if your ears feel full, if you have tinnitus, if you're detecting symptoms of noise-induced change, then you would not want to rely on the app telling you it's safe. You would want to do something to turn down the sound level, leave the loud environment, or add hearing protection.
Mm-hmm. Mm-hmm. And certainly, as you mentioned, there's the Apple Watch. Comes in many forms. We're seeing more and more interest in protecting our hearing through limiting noise exposure. So we're getting a few questions about the same topic, about preserving your hearing, and they're coming from people who are users of cochlear implants. Do the same principles apply? Is electric hearing the same as acoustic hearing? So what recommendations, number one, Colleen, do you have for noise prevention of hearing loss through noise exposure? And two, is tinnitus the same if you're a cochlear implant user as you would be if you have acoustic hearing? So I'll open that up to the broader panel. So Colleen?
Yeah, so I can try and start. I'll say up front, I have not worked at all with people who have cochlear implants, and so I will offer some general guidance and speculation, and then ask Rich to take over and talk a little bit more specifically about other clinical populations. The basic strategies for any group that I would offer, whether it's someone who has a hearing aid, a cochlear implant, or normal hearing, would be to turn sound levels down when you can, to limit time in a particular environment when you can't, and then to consider hearing protection. Now, for people who have a hearing aid, hearing protection becomes a little bit trickier if you put a pair of earmuffs on top of hearing aids. There can be a lot of feedback issues. Certainly earplugs are a difficult option with needing to remove your hearing aid. one of the things that has been at least discussed is, again, the idea of these electronic hearing protectors, because they have some amplification properties as well. And so they'll have a volume setting for both the earplugs and the earmuffs. And for somebody who has potentially a milder hearing loss, they might be able to get some amplification that offsets having removed the hearing aid. For somebody with a more severe hearing loss, certainly that's not going to be an adequate amount of amplification. There are some manufacturers who are now working on a programmable earplug that would, when it's allowing sound in behind the electronic earplug, would actually have a filter that's programmed to match their hearing loss. So there are some companies that are trying to tackle that issue of hearing protection for people with hearing loss. With cochlear implant users, I'm less confident of what guidance we would be able to provide in terms of hearing protection, given that the processor doesn't rely on sound that's coming into the ear canal. You could put an earplug in, but the sound will still be picked up by the microphone that's outside the ear. And so limiting the sound exposure would be the starting point. And then the dynamic range and the extent to which it has limits on how much voltage will actually be applied, no matter how much the sound is increased, would be my other thought on implants. But Rich, do you want to talk a little more about some of those special populations?
Yeah, so I'll just say, keep in mind with cochlear implants, there are patients that have acoustic hearing and electrical hearing in the same ear. And those acoustical hearing aspects need to be considered in the same thing we've already talked about. If you're only hearing electrically, as Colleen mentioned, that you can control the maximum output of the cochlear implant by controlling the electronics of the cochlear implant. And that could be done. You could have different memories, just like you can in hearing aids, to different listening situations with your cochlear implant. I will also say that I've been working for many years on trying to develop cochlear implants for tinnitus. And indeed, there are lots of patients we've seen who get cochlear implants who say, oh, well, I can hear better, thank you. Even better than that, my tinnitus is gone. Now, that doesn't happen all the time. There are a small group of people who actually get tinnitus from after receiving a cochlear implant. But for the most part, people that already have tinnitus and they get their cochlear implant, the majority of those patients experience a benefit in their tinnitus because of the cochlear implant, because they're hearing sounds probably. And now, fortunately, I've been trying to do this for years, the cochlear implant companies are also providing some background sounds, just like the hearing aid companies are. So now, just like with hearing aids, you can select different background sounds, you can control the level, have different programs, whether they're on or off, on some of the cochlear implants. So I think that's a major advantage and a major step forward for cochlear implants and tinnitus.
Good. In fact, you advanced me to the next question, Rich, because that was one of the questions, is that should we be asking cochlear implant companies to do more, as one listener had wrote in the sense of having more support systems, apps like we see with the hearing aid companies. And it sounds like there's progress on the horizon. Is there, what do you think would be the next step that people could turn to until these developments become more available? You've already talked about mindfulness. You've talked about other types of cognitive therapy approach. Is there anything that we've left out that may be specific to CI users that we haven't really addressed?
Well, I think all the things we've talked about, for whether it's hearing aids or normal, so-called normal hearing, or cochlear implants, I think any of the counseling procedures that have been discussed can be helpful for the individual. And again, the individuals are all different. The cochlear implant companies, as I said, are now using, at least some of them, background sounds. And I think part of the problem is, and this is true for audiologists and cochlear implant audiologists is a lot of audiologists are uncomfortable working with tinnitus patients and not sure what to do and how to be helpful and what strategies to take. And so if you're in a cochlear implant clinic and you're busy and you're focusing on setting cochlear implants, and all of a sudden someone starts talking about their tinnitus, the question is, how do you help them? And how do you spend the time? And so I think now that I think people are becoming more comfortable and realizing that if they provide tinnitus and hyperacusis counseling and devices, they will see more patients in their clinic. And if they're prepared for those patients, that will be good for the patients and good for the clinic as well. But it's taken some time to get there.
Certainly, and I'm seeing in the comments section that some of our listeners are audiologists, and they're reaching out because there is a lack of, traditionally there's been a lack of science to support certain approaches being used, but that's changed in the last 5 years. We see more and more research being done and randomized controlled studies and various ways of offering counseling online. And so it's nice that we have audiologists here online trying to learn more so that they can incorporate things into their practice. Lynn, do you want to add to that? What, from your perspective, what do you see in terms of your population?
Well, for our population, I think, we have a great deal of solutions that we've adopted from the surveillance sector, and also that have come from research within the DoD and Department of Veterans Affairs. It's a matter really of making that care accessible to our patients, and a lot of that is ensuring that our providers are aware of these different techniques and different programs and be able to train them and have them feel confident with providing that care. In terms of cochlear implants and tinnitus, we don't see very many cochlear implants in our population. So, I don't have much experience with that. But I did see a question earlier. Somebody was asking about the progressive tinnitus management and whether or not that was evidence-based, and in fact it is. Dr. Henry and his team have done several randomized controlled trials for PTM, and I sent a link for the NCRER, which is his laboratory website, that lists a lot of the work that he's done, and also other scientists there who have done work with traumatic brain injury relate and tinnitus. So if anyone's interested in that, but a lot of it is getting the best practices into the hands of the providers so that we can have it available to our patients and the general public.
This has always been a challenge, I'm an audiologist as well, whether we just, because everyone is different, as Rich says, it almost lends itself to try anything, which then can easily go off track to people perpetuating certain stories that this may help or that may help, and it's not regulated. So as people who are hearing healthcare professionals, I'm speaking to the listeners now, we make an oath to provide services that don't hurt people and that we are mission driven in providing evidence-based services. And so until the research has been done and until there is evidence to provide a treatment or an assessment, we are apprehensive to do so. So that's part of what we're having a discussion about now. Lynn, along the same line, there was an earlier comment about the relationship between post-traumatic stress syndrome and tinnitus. So in addition to, the question was also about head injury earlier, but maybe can you tell us a little bit more about PTSD and the relationship between tinnitus and management? Yeah,
well, we are finding a relationship. Again, for the Department of Defense and for the VA, PTSD research is very prominent, and we're learning more about tinnitus in those patients. And actually, at the Hearing Center of Excellence, we have a new scientist that actually is from the University of Texas in San Antonio, John Mooring, who is is doing a lot of work with tinnitus and PTSD, and he's joined our lab. He's got a grant, and he's just placed in our facility as he does his studies. We're help facilitate getting some of the subjects for his project. But so he's done a lot of work in that area, and we're just trying to understand it better. But there is an association between PTSD we're finding. It's not in everyone, and tinnitus.
Yeah, certainly. Okay. So I think what I'll do is there's a few final questions that are coming, and they're kind of smattering different topics, and we only have a few minutes left. But I want to touch on them. So Lynn, since you've got the mic right now, two of them relate to why aren't there many cochlear implant users in the vet service member population? And one of the other questions has to relate to cochlear implants and hearing aid noise reduction, compression devices, activation, and things like that can contribute to excessive noise amplification. So starting with Lynn, maybe you can talk a little bit about, following up on that comment about why aren't there many CI users in your population?
Well, first for the active duty military, can you hear me? Mm-hmm. For the active duty military, when a person comes into the military, they have to meet certain hearing standards because there are critical hearing skills that are necessary for many service members, for most service members. So there's a requirement for a service member in all the different services. It's the same, to meet certain hearing standards. And through their careers, they have to meet certain standards. There's what's called a hearing profile system. And if the hearing gets to a certain level where even a hearing aid doesn't get them into a certain range, then they can be just discharged from active duty. Now, during Desert Storm and Operation Desert Iraqi Freedom, there were a few active duty service members that had very traumatic injuries and were given cochlear implants, and they stayed in for a while, but I don't think they're in any longer. So there's a requirement in the military to be able to have a certain level of hearing. Now for the VA does fit cochlear implants for adults, and I think the last I heard was it was about 300 a year, but the VA does do cochlear implants for those veterans who have, for whatever reason have gotten that level of hearing loss, and they do fit them. So there are, and DoD and VA have a coordinated effort for locations that actually fit the cochlear implants, but also in the military, and I'm talking about dependents, which are children or family members. If they require a cochlear implant, the Department of Defense does fit them with cochlear implants. But the service members, certainly if they have an injury, they will. But we don't see many of the active duty population because of the requirement to have a certain standard of, a certain level of hearing and certain abilities.
Okay. Thank you. So we'll wrap it up with the final question going back to where we started, and that is preventing hearing loss and tinnitus in the first place through noise exposure. And so it's a two-part question, as you can see in our chat room. People really want to understand are noise reduction or compression activation type devices in hearing aids, and it says that some cochlear implant, they're asking cochlear implant microphone levels can be adjusted appropriately. Are these two effective means of trying to reduce excessive loud noise exposure in the case of hearing aids, or excessive stimulation with cochlear implant users? I'll throw that out. And then Colleen, the final question you'll be able to take it home is understanding more about the predisposition. We have someone asking about whether there's a predisposition for hearing loss if women who are pregnant, if they're smoking. So let's start with the mechanical part of how hearing aids and CIs work. Maybe Rich, you can speak about that, or Colleen, you can speak about that in terms of preventing excessive exposure to damaging sound levels. Anybody?
Well, I'll just say that, of course, impulsive noise is typically thought of as being more damaging than continuous noise. And so you can get tinnitus and hyperacusis from a single impulse. So that the reaction time of gain controls for cochlear implants and hearing aids need to be able to deal with rapid onset time sounds. And so that's an issue that would depend upon the implant and the hearing aid company and how they're set. So that's the comment that I have.
So, for example, if you're in a restaurant and suddenly somebody drops the whole a tray of dishes, that's gonna activate your prosthesis in a way that will hopefully limit the sound pressure level in the acoustic sense of creating some damage in a way that was not necessarily the same as having exposure to continuous sound as it might be an engine working next to, that's next to you for 2 consecutive hours. So that's a good example of describing the difference between impulse or a continuous noise. Obviously, there are other examples of impulse, but certainly some of those brief experiences can be very damaging. And Colleen, thinking about predisposition again, what do we know about the correlation between smoking and potential other risk factors in being predisposed to potential noise damage?
Yeah, there is just a little bit of work on smoking, and in general, the studies that have looked at smoking have seen some correlations with increased hearing loss or increased noise-induced hearing loss. Again, the major challenge is all of the confounding factors and behaviors that can go along with smoking, and whether the observed relationships are directly related to smoking or related to cardiovascular disease that might accompany years of using tobacco products and having some underlying lung disease. So I don't think that we have really strong relationships we can point to, other than there's lots of health reasons for choosing not to smoke, and potentially some benefit to the ear is one of those possible health benefits. Part of the question was related to pregnancy. I don't know of any data looking at whether there's an increased risk of noise-induced hearing loss during pregnancy. It'll be something interesting to monitor for. Barbara Canlin's lab is doing more and more work looking at hormones and relationships between the elevation of particularly the female hormones, estrogen and progesterone. And so as more is understood about the relationships between hormone levels and vulnerability to noise injury, we might have some insights into those relationships, but that's not really very well understood at this time.
Okay, well, thank you for wrapping us up on that note. And I just want to take this opportunity to thank our listeners for joining in and adding your questions and answers, because as much as our speakers like to be on stage and provide information to a group, sometimes we're not able to hit the targets of things that are of particular interest to you. So thank you for putting yourself out there and asking the questions. And I want to thank our speakers for making themselves available as a one-on-one type of opportunity to meet the scientists. Clearly, you are all making such huge contributions to our field that impact people with hearing loss. And we thank you for your science, and we thank you for your careers that are dedicated to improving the quality of life that is compromised by excessive noise exposure and tinnitus and all the other related auditory type symptoms that can interfere with holding down a job, having a good relationship with a spouse and family members and friends. So personally, I want to thank you. I know our listeners are thanking you. And on behalf of everybody, we'd like to thank our staff at the Hearing Loss Association of America who's made this convention possible virtually. And I want to thank our leadership, so Barbara Kelly and our board of directors, for pulling this all together in a way that really can connect people around the nation and across North America to listen in and learn as we go, and even despite it being through this virtual format. So on that note, I'll thank you all, and we can all wave goodbye. And we hope to see you in person next year. But if not, you'll see us virtually for sure. So thank you.
Thank you.
But